Can you hear? Sven, can you hear me?
Hello, yeah, I can.
Oh yeah, hi. Usually Chris comes on as well, so I'm sure he's probably working in the background. Have you just joined, or have you been trying a wee while longer?
No, I just joined and it just worked on the first.
Okay, good.
Right.
You can
That's
see
good.
there's a share screen for you to share your PowerPoint presentation. But
Yeah.
I hope Chris is coming, because he's the one that has to video record, because I don't think I have a record button.
No, okay.
Yeah.
Let me just try to share the screen and see if how that works.
Oh, there's. Oh no, that's you sharing the screen.
You're sharing. Yeah,
well,
seems like that's working. That's nice. It's good for everything that works.
Yeah. So you can then press on the slideshow to show it. So that's it.
Yeah, exactly.
Hold on. No, you've just stopped sharing again, but you're all good to go.
Yep.
Yeah. There's a button at the bottom for questions, and there's a comment thing at the side. But if you want, you don't have to worry about those. I can keep an eye on those.
Okay.
You can just do your talk, and I'm going to introduce you, and then I'm going to leave the presentation, so it's just you talking, but I will still hear you. And then when you're finished, I'll come in again and thank you and everything else, and I'll go through the questions and ask the questions, and then you can respond. So the people are not speaking to you directly, but they might comment on the side.
Right. All right. That's fine. And great that you are monitoring that, because that's too much for me to keep track of.
Yeah. And one of the speakers was trying to keep track of it, but it really is quite, it's quite what do you call it? It takes your attention away from your talk, because
exactly. And I think everybody is distracted by that. So
and the comments are oftentimes just, oh, good point. You don't need to read that. You can read that later. And if they have questions, quite good the way they have done this. If there's questions, then people can prioritize, so that they don't have to ask the same question over and over again.
Yeah, exactly.
So there's there are people now starting to talk on the. So I don't know if they can hear us yet. Usually Chris is here, so I don't know what's happening. Can people? You can hear us?
Yeah.
Yes, we can hear you. So okay, so that's great.
At least it works. Yeah, it works at least.
we haven't said anything bad yet.
I don't think so. No. We were about to.
No. We're about to. The people can put the questions into the questions box, and then prioritize the question, so people don't have to ask the same question over and over again. And I'd ask a question from the top down. That means the question that is of most interest to everybody. So okay. Okay, so I'm just hoping that it's 7:30, so I don't know where Chris is. So I hope he is in there in the background somewhere, because otherwise I'm saying this is videoed, but I don't have control over the video unless I have something here. Let's check here. No, that's not.
There's people from all over the place.
Yes.
Hi, Lisa.
Yeah, it's usually great. We have got, you can see there's somebody from Arab Emirates, and Lisa are all from Sweden.
Yeah, exactly. Yeah.
And from California, and from Belfast.
California, yeah.
So it's great. Well, let's make a start and hope that we are being recorded, because, as I said, usually we have Chris here, and he does the recording. So anyway, well. Good evening, or good morning, or wherever you are in the world. It's evening in Belfast, and it's a little bit earlier, I think, in Sweden, or in Norway, sorry, for Sven. We are delighted to have Professor Svein Eikeseth here this evening, or today, for our webinar series. I'm sort of thinking Sven probably doesn't really need an introduction, because he has written some of the most seminal papers in EIBI and especially related to autism. But I'm going to just give you a quick overview. Sven has been working at the University of California in Los Angeles in the mid-80s under the supervision with Dr. Lovas, before becoming a PhD student at the University of Kansas. And he gained his PhD over 30 years ago in 1991. It's actually the same year as myself, in developmental and child psychology under the supervision of Donald Baer. And Donald Baer is one of the giants in our field, obviously, so that must have been an amazing experience. Subsequently, he returned to the UCLA working as a postdoc fellow in the Young Autism Project for about a year, and then on returning to Norway, he received clinical training at the University of Oslo and is a certified clinical psychologist. Sven has directed 2 UCLA multi-site Young Autism Projects replication sites and continues to oversee the clinical and research activities at the UK Young Autism Project and other settings in Europe. Currently, he is a professor of psychology at Oslo Metropolitan University in Norway. He's published a number of peer-reviewed research articles and books, chapters in autism and applied behavior analysis, and he is the author of, one of the authors of some of the best-known outcome studies and meta-analysis evaluating early intensive behavior intervention for children with autism. So without further ado, I hand you over to Sven for what is going to be a fascinating presentation, I'm sure. We will have questions if people want to put questions into the question section. Sven has said he would be happy enough to answer some of the questions later on. So Sven, you're more than welcome to the Center for Behavior Analysis, and it's over to you. Thanks. I'm going to leave the presentation and I'll join you when you're done, okay?
Thank you, Carola, for those kind words, and hello everybody. It's evening here in Norway, and probably I see there are people from all over the place on lockdown, and that's very nice. I'm really pleased and honored by that, and also I'm very honored to being invited to have this talk. It's a great honor and a pleasure. I will stop looking at you. I'm looking at who's on the screen, so I will stop doing that, and I'm going to try to share my screen. And that's the first challenge of this evening. Should be working soon. What I'll be talking about is some research on predicting outcome of early intensive behavioral intervention. And I hope you can see my screen now. Can you just let me know, because now I can't see you anymore. So if you can just let me know if you cannot see my screen. Just
we can see your screen.
Yeah, okay, perfect.
You have presenter view, so if you wanted to put the slideshow on, but presenter view is fine too.
Okay, so the slideshow is not on. Okay, it's for me it's on, but it's better to get the. You have the slideshow now.
Down there, yeah, that one. Oh no, that should do. That's fine. We can see the next slide small, but that's fine.
Okay, yeah, that's if it doesn't bother you, you can do that. Because yeah. Anyway, so I guess we start. And what I was going to talk about was predicting outcome of early intensive behavioral intervention. As you all know, EIBI is an empirically supported intervention which may help improve the cognitive and adaptive functioning for many preschool-aged children with autism. But there's still a need to identify characteristics that may predict outcome, because we haven't really learned enough about that yet. There's also need to do much more outcome research. We are lagging behind now in EIBI and ABA interventions for children with autism, because other researchers researching other types of intervention are actually doing better research than we are doing now. So that has to stop, and we need to be better at doing more and more research. And what is needed is really some randomized controlled trials of comparing EIBI to some other interventions or to treatment as usual. And so that's really something that I hope a lot of. It's very important actually, because we do have very good data showing very good effects, but the methodology is not good enough yet. So we need to be doing more outcome research as well. But for now, I'm going to talk about predictors, what variables can predict outcome. And what has been looked at in the literature is like pre-treatment variables. And what has been studied most, I guess, is intellectual functioning. If that can, at intake intellectual functioning can predict outcome. Adaptive behavior at intake, age, chronological age at intake, social engagement, toy interests, preference assessment, and stereotype behavior has also been studied. And the ones that have some asterisks behind, I'm going to be talking about this presentation. There's also treatment variables that are important, and one is early response to treatment. It seems that can predict the later response to treatment and outcome. Treatment intensity, the length of treatment, the quality of the treatment, and the supervision intensity and quality of supervision, and parental improvement and parental stress. These are variables, and there also add other variables, but at least these are some variables that can be important. I will start by talking about intellectual functioning. And a lot of studies have shown that high IQ at intake, high cognitive score at intake, is associated with high IQ at the end of treatment. And I've listed some references, but there are also more studies showing that. This is a very robust finding. So basically, if you start high, you're going to end up high, which makes sense, of course. But if you measure change in IQ instead of where you end up, then it's not so easy anymore to find intake IQ as a predictor. So if you say that if you have an IQ of 50 at the start of treatment and 70 at the end, you have gained 20 points. And if you have a start of 90 at intake and you have 110, you still gained 20 points. So that's both have a change of 20 points. And when we measure a change in IQ, then intake IQ is not so longer a clear predictor outcome. There are a couple of studies in Israel that have shown that intake IQ predicts IQ change, but our research lab and our colleagues have typically failed to find that. So there's a number of studies which I've listed here that don't find that relationship. So basically, if you look at just the outcome score, then intake IQ predicts well. If you look at change as an outcome score, then that is not so clear anymore. Basically, often we don't find that it predicts. Another predictor that has been looked at, or variable that has been looked at that may affect outcome, is age at intake, chronological age at intake. And the first study that I heard about was Harris and Hendelman in 2000. They found that if you measured school placement as outcome, then intake age predicted better outcomes. So younger children had better school placement and more advanced school placement than children entering at the older age. There's a study that I'm going to talk about with a Grand-Pichet study. I'm going to talk more about that in later, but basically they found that if you have more hours of intervention, you likely have more treatment goals met. So you make more progress in treatment as measured by meeting treatment goals. So also there's study that finding that chronological age, this is Canadian data, is associated with better cognitive outcomes of a community-based intensive behavior intervention. And that this is not so much the case in older children. So what the Perry and colleagues found was that in younger children, it seems like chronological age will predict outcome of the community-based intervention they're providing, behavioral intervention, but not in so much in older children. And then lastly, Smith and colleagues, they did find that age at intake predicted outcome on actually several measures, including cognitive functioning, adaptive behavior, and autism severity. So I think that is the study that I've seen so far that is show more predictors, or that intake age predicts more variables, basically. But then we looked also at the change again. And then we have a little bit of the same story as with IQ, that it's less evident when outcome is measured as change in scores between intake and follow-up. And when we do that, we and other colleagues have failed actually to find a relation between age at intake and change. This also includes data from 3 meta-analyses, one which I'm going to talk about a little bit more about later, the Eldvik et al. So again, if you do measure change, these variables that seems to predict outcome is not so strong anymore. I saw there were some friends and colleagues from Sweden on, and these are some data that we are working on, collected in Sweden at the Banyan Center, that was a rehabilitation center for children with autism, basically providing supervision to families and preschools serving children with autism in Stockholm. And basically, one of the things we looked at there was predictors of outcome. And what we did measure was adaptive behavior, as measured by the Vineland Adaptive Behavior scale. So probably a lot of you know, and that has a overall score, and then has several subscores. So it's one of the subscores is social behavior, one is communication, one is daily living, and then for little ones you have motor skills, and then you have a maladaptive behavior. And basically what we looked at was age at intake, and treatment intensity, and treatment quality, and treatment acceptability. And I'm going to talk a little bit in detail about treatment acceptability, but we use something called the abbreviated acceptability rating profile, AARP. It's short for that. Basically, what we found was that children did improve between intake and follow-up, which was that was 14 months of treatment, basically. So between intake and 14 months of treatment, they did improve on adaptive behavior, communication, and then they have a decrease in maladaptive behavior. And what we found was basically that intake adaptive behavior measured by Vineland that basically predicted everything at outcome. So higher Vineland score at intake predicted higher Vineland scores at follow-up 40 months later, actually 18 months later, it is, and also all the subscores. And also it predicted less maladaptive behavior. So that was a pretty strong predictor. But that is only, at this stage, we haven't looked at change. We looked just at if it predicts outcome. What we did find, which was a little bit surprising, that was that treatment quality and treatment intensity was not associated with outcome. So we didn't find a relation between treatment intensity and treatment quality and outcome, which we are still looking at. We used a multiple regression analysis, but we're going to do some other analysis also to see if it gives different data. But in a multiple regression, we didn't find really that did predict outcome. But what we found was that treatment quality that improved over time, which is not very surprising because, you know, if you have when you're working with a child over some time, having supervision, your treatment skills should improve. That's what we found. But also, if you have been working, I don't know, many of you are probably clinicians, and many of you are probably giving supervision to therapists and treatment personnel. And what you might have found yourself, and definitely what I've found myself, is that in a situation where some are very difficult to supervise and some are very easy to supervise, in the sense that some seem to be catching on treatment skills quickly, and some seem to be catching on treatment skills very slowly and maybe not catching on at all. And what we did find was actually, if you had a treatment quality, lower treatment quality at intake, if your teaching skills were less good at intake, lower at intake, that also predicted lower treatment skills 14 months later. So basically, the ones who started low had a tendency to continue to be poor or low in teaching skills, which is actually sort of what I would expect from clinical experience. But I think it's nice to have those data. We did find that high treatment intensity was associated with better treatment quality. And also, what we looked at was the next slide was the AARP scale, which was the treatment acceptability scale. Basically, treatment acceptability didn't predict outcome, but what we found was that the treatment acceptability was really, really high. And what you see here is this scale has 8 actually questions that are very simple, and we asking the parents and we asked also the therapist. So those questions we asked was that this is an acceptable treatment for a child's behavior. And then you rate it on a Likert scale from 1 to 6. So 1 is disagree and 6 is very strongly agree. The treatment should be effective in changing the behavior, the child's behavior. The second question. The third question, the child's behavior is severe enough to justify the use of this treatment. I would be willing to use this treatment with my child. this treatment would not have bad side effects for the child. I like this treatment. The treatment was good, was a good way to handle the child's problem. Overall, the treatment would help the child. And basically what they found was that the mean score of the therapist was 5.5 and mean score from the parent was 5.6 of max 6, which I think is important because there's a lot of people now saying that early intensive behavioral intervention or ABA is actually harming the child. It's like it's bad for the child, and at least we have some evidence here that basically many parents and also therapists, they don't seem that is the case. They think that this actually is a very appropriate type of intervention. So I think that was a quite important data to mention here. I didn't mention that we had a number of children, was 171 children in this study, so it's quite a big group. I think I mentioned most things here. So basically, higher intake adaptive scores predicted higher adaptive scores at follow-up, and all the subscales, I mentioned that. And children who started treatment at younger age gained more communication skills. Children who received higher number of treatment hours received better treatment quality. So that was I mentioned that briefly, is that even though treatment hours did not affect outcome directly, it had an effect on treatment quality. So that if you were doing more hours, you basically would be a better therapist, which also kind of, I think, makes sense. And there is a limit of, I think, how few hours you can do. That's a threshold. If you do too few hours, you can never really, or never is not a good thing to say, but it's more difficult to become a good therapist than if you do quite a few hours of therapy. And that the parents' score on the treatment acceptability and also the therapist score was very high. There is I was thinking about talking a little bit more about treatment intensity. There's a study, interesting study by Sigmund Elvik and colleagues. Sigmund's a good colleague of mine. And they did a nice study where they studied 3 groups of children. One was a low intensity treatment group who received about 11 hours on average of EIBI. There was 21 children. And then there was another group of children who received 18 hours of EIBI. And that was 36 children actually. And then was a third group of 17 children who received treatment as usual. So basically there was a low intensity group of EIBI and a higher intensity. It's not really high intensity, for it's 18 hours. And then it was treatment as usual. And this is just taken from the study. And what you see, these blue bars are actually individual children. And all the way to the left is the treatment as usual comparison group. And basically, you see that some are going down and some are going up. And basically, that is the change of score. So see, the first child has a change of -20. This is in Vineland Adaptive Behavior. About a change of -20. And the one all the way to the right of the treatment as usual group has a gain of maybe 18 or something like that. And then the mean change of that group who received treatment as usual was -2.1 points. And these are standard scores. And then the group that intensity EBI. I guess it's wrong to say EIBI because it's not really intensive. So it's EBI. That was about 11 hours on average. They had a mean change of 3.2 on the Vineland. And the group that had a higher intensity EBI, they had a gain of 8 points in adaptive behavior. So basically, there's a difference in basically showing that little ABA or little EBI that helps a little, and moderate EBI helps more basically if you compare to a treatment as usual. So I think this is a good, interesting data. Unfortunately, so is the two different treatment sites. So the treatment site that did the low intensity treatment is an Oslo site, and the treatment site that did the higher intensity is a Bergen site. So that's a bit of a confound. So you have to keep that in mind. But the treatment should be quite uniform across sites. So, but still, we don't know for sure. And also, I mentioned the CARD study, Grampeche and colleagues from California. They did a study where they compared. Basically, they looked in their files, and they looked at how many hours they were billing, basically, because that's how they measured treatment intensity. And then they showed how many treatment goals had been met. And this is 245 children, so it's many children. And basically what they found was that children between 2 and 7 years, there was a significant increase in skills based on treatment hours. This is what you see here. So the blue is children between 2 and 5, and the green is 5 to 7, pretty much. And then on the x-axis is treatment hours per month, and the y-axis is mean master behavioral objectives. Just counting how many behavioral objectives was met. I also quickly mention the meta-analysis by Eldvik and colleagues, where we looked at 309 children who received the behavior intervention. And basically, I see the time is going, so I'll be a little bit quick. Basically, what predicted best in that meta-analysis is actually treatment intensity. You can see that where the errors, the blue arrows are. So the treatment intensity predicted both IQ and Vineland score. There was an interaction between intake Vineland scores and treatment intensity also. And also IQ intake, did that predict outcome on IQ? But basically, the only thing that predicted both IQ and Vineland was the intensity of the treatment. So these are probably the strongest data that we have. We also have looked at intensity of supervision. And this was a study that was a spin-off. This is data collected in the UK, a Young Autism project. And there was a spin-off of an outcome study that we did publish around that time, the same year actually, where we looked at the intensity of supervision and outcome. Basically, we had data on how many hours per week and month each child received supervision. And then we had taken data at intake and follow-up, outcome data. We could see if there was a correlation between that. Basically, it was 20 children in this study, and they received intensive behavior intervention, EIBI, so it was 34 hours a week, or 1-to-1. And supervision per week, that ranged from 3 to 8 hours. So it's quite intensive supervision for these children. And follow-up was done 14 months after intake. So the intervention was 14 months. And what we found was that supervision, that did predict IQ. So basically, more supervision on average resulted in higher IQ score for the children. And intake IQ, these are change in scores. So basically, supervision predicted change in IQ score. And IQ did not predict change in IQ. But what we found was that what we call here visual spatial IQ, that was also a strong predictor of change of IQ. And Vineland composite, that is the adaptive behavior, was not. And what we found also in some other studies we have done, because when we did the multi-site replication research, we did 2 types of IQ tests. One was like a global IQ test, cognitive test, which measured both visual spatial skills as well as verbal reasoning or verbal skills. So that was a type of sort of standard IQ test. Usually Bailey scales of infant development or Wechsler tests. But we also did a test called Merrill-Palmer. And that was a test that was actually developed for deaf people. So they had no verbal items, just only, there was a couple of sort of language comprehension. There was a couple of verbal items, but almost all of them were non-verbal. So it's basically manipulation of puzzles and pegs and so on. And that, because children with autism have been found to have better visual spatial skills than verbal skills, this test was actually quite a bit used before for children with autism, both in the States and also I think in Europe, at least in Norway it was used, and also in the States. So basically what we did, we also did that test, and that is the test that actually showed effective in predicting also change in IQ. And I think that I'm going to talk about a little bit about that later, because I've been warning about that for a very long time. Why is it that this visual spatial skill, if you're good on manipulating puzzles and pegs and so on, why would you do better in treatment, basically? And this is not the case if you have a higher IQ, overall IQ. That doesn't predict. It's the visual spatial that predicts. So that's quite interesting finding, and we've seen that several times. I'll come back to that actually. But for this story, is basically that the supervision did predict change in IQ. It didn't predict change in Vineland, but it did in IQ. And also, this is just the individual children and how many hours of treatment they received, and their change in the gains in IQ. It's probably a lot of information there, but and I might be talking fast. So basically, so far at least, there's no sort of clear-cut answers to what is the best predictor of outcome. And as I also mentioned, it depends how you measure outcome. If you measure change, or if you measure just what score you have at when you end the treatment. And some studies find relations, and some studies do not find so clear relations. But I think that the meta-analysis, Eldvik 2010, is pretty strong, sort of in the favor of treatment intensity, definitely. And the reason why change maybe is not is hard to predict is because we have a fairly effective treatment, so it can help, children on different levels. I think it can help children that are low functioning. It can help children that are higher functioning, and it's effective for sort of all ranges. Is probably what I suggest. So therefore, where you start doesn't really predict how much you're going to gain. It predicts about how high you're going to end up on the scale, but doesn't predict how many points you will gain from treatment. Which basically I think suggests that yes, this treatment is actually quite effective for the different levels of functioning also. But this is next PowerPoint you see slide here is an interesting study by Ulrika Long from Sweden, Stockholm. She did her PhD, and one of the studies for her PhD was this one, where the quality, looking at quality of behavior intervention as a predictor of outcome. And this was a study where we had 30 children who got behavioral intervention, EIBI, and Ulrika used something called the York measure of quality of intensive behavior intervention to measure the behavior intervention. And this is a scale developed in Canada by Adrian Perry and the colleagues. And she translated that into Swedish and did a couple of studies with it. And this is one of them. What she did, excuse me, what she did measure was outcome after 4 to 6 months, and that is a bit difficult actually to. It's quite a short period, so I was a bit worried about that because 4 to 6 months is not a whole lot of time to measure outcome. But that's what was done, and basically there were some interesting findings. These are just the items of the York measure of quality of intensive early behavior intervention, and as you see, it is quite familiar items on it to I think what you would at least you would recognize all of them, I think, basically. So it's looking at presenting the discriminative stimulus or the antecedent. It's maybe better because they're not only discriminative stimuli. There might be conditional stimuli as well. But the antecedent, presenting the antecedents, how it's done, if the attending is okay, and if it's varied or not. How the reinforcement is presented, several variables on that. Prompting, if that's done correctly, if the fading is done, and how you organize the teaching, how the teaching is organized, if the materials is accessible and you have seem to have a clear plan and teaching goals, the pacing of the teaching, the length of intertrial intervals, and so on. Intensive teaching, which has to do with the pacing. The teaching level, if you were teaching at the right level for the child. If you have sufficient instructional control of the teaching, and if you are performing generalization appropriately, and if you are also addressing problem behaviors appropriately. So that is basically the what the scale is measuring. And the YMQI has an average item score, and the average item scores that did predict outcome. Basically, what it did predict was that it predicted progress on programs, basically. So when we measure progress as how many how you did in matching, how you did in listening behaviors, receptive behaviors, how you did in tacting, amending, expressive language. If you measure in that way, progress in that way, which you probably have to do in such a short intervention as 4 to 6 months, then the average item score overall that predicted the outcome. Also, what Ulrika did was she categorized it as in no progress, medium progress, or low, medium, and high progress. And I think that's something we're going to try to do with this data from Sweden, from Weinmann as well, because I think that's a good way of looking at the data also. Also, 2 of the 4 subscales on the YMQI, the York measure of quality of intensive behavior intervention, and that was organization and teaching. They predicted outcome on the same variables, and also some of the items: relational reinforcers to task, differential reinforcement, implementation of error correction, and mixing tasks, and teaching embedded in naturalistic activities and response generalization. So they were predicted by they predicted the outcome, basically, these variables. So this is a strong, I think, study or strong indicator suggesting that the quality of treatment predicts outcome. And so this is a very, I think, it's a good and important study. I did mention earlier that visual spatial skills predicts well change in cognitive skills. So basically, if you're good at manipulating puzzles and doing pegs and interested in or you're good at manipulating objects, then that is a good predictor of outcome. And that led us to a study that we did, so data at the Yale University. Lars Klintvall, who was a PhD student at that time, he went to Yale to study with Chavarska and colleagues. And there he came over a bunch of data. That's very interesting, or could be interesting. Basically, what they did there was that they had 70 children that was assessed when they were 2 years of age. And so basically, they had children that came in for diagnostic assessment and at 2 years. And they were given an autism diagnosis, many of them. In this case, it was 70 children. And then they got 16 months of some type of intensive behavior intervention. Not necessarily EIBI, but definitely intervention that had to do with behavior analysis. And these children, they were assessed on ADOS because that was part of their diagnostic workup. And also they had our IQ's assessment, and Bolin scale was used. So basically we had, and these ADOS sessions, they were videotaped. So we had 70 videotapes of these children and the therapist doing ADOS, which is you're probably familiar with ADOS, which is a diagnostic assessment. Basically what you do is that you present, interact with the child, ask questions and give show toys and objects and try to interact with the child, and then you score basically the child's social communication and social interest and social behavior. That's really what you score on the ADOS. So basically you end up with a score assessing these social behaviors, social communication, and then you will end up with a cutoff which is within or not with autism. But I mentioned that these assessments, they involve presenting toys. So what we figured out, since we had the videotapes, we figured out we could look at how they reacted to these toys that they were presented with. So we made a scale for that, basically. And what we did was that, if you see here, this is actually the scale, and all the way to the left is the toys that are presented during ADOS or interaction, not only the toys, but most of the toys. So it's a pop-up toy, so toy telephone, vehicle, shape sorted, bubbles, balloon, edibles as well, doll, remote control, toy, and the peekaboo, basically. And then we figured out we could score. We can't score it if these items are reinforcers or not, obviously, for the child's behavior. That's impossible. We could score how interested are they in these toys. So basically, if the children ignore basically the toy, then we scored it no interest. And if they activate the toy once or twice or show a little bit little interest, and high interest, we scored if there was a frequent activation, for example, or frequent interaction. Then we scored as a high interest. So basically, we had a scale from 0 to 4 of interest. So then we had intake age, we had intake IQ, we had intake scores on ADOS, standard score, regular scores on ADOS, and then we had this toy interest score as well. And then we see which of these, if any, would predict outcome. And basically, what we did find, which is, I think, many are going to be surprised about, is basically that ADOS did not predict Vineland. Actually, I should point here because that's what you can see. So basically, ADOS total score here, that failed to predict Vineland outcome. It failed to predict Mullen IQ. And we divide that into actually verbal and non-verbal. So I have verbal Mullen and non-verbal Mullen. So verbal IQ and non-verbal IQ. And basically, ADOS didn't predict any of the variables. So basically, children who were more social didn't do better at outcome than children who were less social. Or children who had more autistic sort of behaviors, as measured by ADOS, didn't do less good on these variables at outcome than children with less autistic behaviors. But what we did was that this ISLA is what we call that interest in toys measure. That predicted clearly Vineland, and it predicted both of the IQ subscales, so both the verbal and non-verbal subscales on IQ. So basically, what did predict if children were going to do good in treatment was basically how interested they were in the toys that were presented in the ADOS assessment. And that's also, so that is really makes sense with the data we had for many years with the non-verbal visual spatial IQ, that we found that also predicted a change. So I think that is something important that we've seen here, and also it's something that needs to obviously be looked more into. But here it seems like it's not really the child's social behavior or that is a good predictor, but it's really our social skills, communication skills, social communication skills, but it's really the children's interest in toys. And there's also some other studies, similar, not similar studies actually, but other studies showing similar results. Toy engagement. Nora Schreibman has done some research on that, and some other also. So it's not the only study, but this is one study that is interesting, I think, because it actually compares the ADOS total score with the children's interest in toys during the same assessment. So I think this is worth looking more into, and I think it, there's a lot of people now, not a lot of people, but at least some people getting interested in showing, because there's something called the social motivation hypothesis of autism, which is basically they're arguing that it's lack of social motivation that is the problem, and that sort of is the result of the children is don't get social skills and not get communication, and that they have a high rate of stereotyped and repetitive behaviors, which the last point really is not so easy to see why that should happen. But there are also some people, including me, who's looking at interest or non-social stimuli, and sort of motivation for or reinforcement balance or reinforcement value of non-social stimuli, that can have to do with maybe with how that we did develop autistic behaviors. And I think that has some relations with this, and showing that definitely interest in there's something with this interest in non-social stimuli, and that certainly could be able to predict outcome, but it also could be related to why you develop autism. Perhaps we don't know that, but that's something that I think is worth to explore. So basically, that's what I had on my agenda, on my list, in my PowerPoint slides. Could have been said many more things, and maybe some different things as well. These are some studies. They're not all studies that are collected. And basically, as you see, there's not a very, very clear-cut answer to this, but I think that basically there is now good evidence that intensity does predict outcome, although it doesn't show in all the studies. And also there's that toy interest is related, visual spatial skills is related to outcome. There's less, or also some that age is related to outcome. Less intake, sort of cognitive skills and adaptive skills is less evidence for that, but also some for that. Then I end on that note, and I'm sure that you will have some questions I'm going to try to answer. Please feel free to ask.
Right. Thank you so much, Sven. That was very, very interesting, and I'm sure it generated a lot of discussion in people's minds and in the future. It didn't generate too much discussion on the chat list, but I think that's probably just because people were paying attention to you and asking. One question that came up quite early on was about a practical question, just about your PowerPoint presentation. Would you be prepared to share your PowerPoint presentation, or would you rather not share it? I mean, it will be.
No, that's fine. I can send.
You could download it there and handouts. Do you see at the bottom of the screen? There's a handouts tab.
All right.
You can just download it there, and then you can.
Okay. Yeah.
Yeah. I'm just wondering. I think that was the main question from the audience, and there was a number of people who were keen to get your PowerPoint presentations. And obviously, I would say that anybody who uses or looks at this is. Make sure that it's properly referenced to Dr. Eikeseth. And Meryl is saying she just wanted to listen to Dr. Eikeseth. She didn't want to put any other any other questions. That was, I think, just people were listening to you because obviously a presentation where you had to pay good attention, because some of the findings I thought were very, very interesting. because we keep saying that applied behavior analysis-based interventions like EIBI raises IQs and raises adaptive skills, and maybe doesn't address autism behaviors as much directly, the social communication behaviors and the repetitive behaviors, but it does raise IQ and adaptive skills. And you're saying really in terms of predictors, the kids that are well switched on socially tend to do better. And it would be a question then, how can we reach the kids that are not so interested? You know, what can we do to help those kids that are not doing so well at the moment? What do you think?
I think basically first I think that we do have more and more data with also autism behaviors, autism symptoms, or what you want to call it, and we do find that you're also reducing autism symptoms with the EIBI.
You can, yeah.
Yeah, many of the more recent studies, because we have been Eldvik, Sigmund have been using the CARS, the Childhood Autism Rating Scale, and we have been using it as well. And when we do use it, we see that actually there is a reduction in
because I mean, there's that whole discussion about people no longer meeting the criteria with good intensive intervention. Maybe they don't, some people don't meet the criteria anymore, whatever that might mean. But obviously we're talking about behavioral criteria, and if those behaviors are not there. I'm involved in some work that focuses directly on the repetitive behaviors at the moment with one of my students, and that's really interesting, because some of the work can actually create more repetitive behaviors if you're not very careful by teaching alternatives. Then they become repetitive, and you really are not much further on. But how would you respond to that whole debate at the moment about ABA-based interventions not being that helpful? I mean, you were saying some of your research, especially for the social validity of that parents and therapists express high social validity, but that's still parents and therapists. That's still not the kids themselves, because they're obviously far too young to really express. How do you feel about, like, for instance, when they object to taking part in the session or in a particular aspect of it, when they get up and walk away and clearly show they don't want to do it anymore for that moment in time, and we would maybe call it an extinction burst and would work through it, but other people might call it they don't want to do it anymore. You shouldn't be forcing them.
Yeah. No, I think that, I mean, we have to. That's a good question, and it's not so easy to answer, I think. But we have to, obviously, we have to look at the child, and if the child is how the child is responding, and if it's aversive. Obviously, if it's aversive for the child, we definitely don't want to insist on doing the teaching. Then you have to change to make it non-aversive. So that's very clear. If you see that this is something that really it's not. It's functioning as an aversive in some sense, then I definitely would stop immediately. But then you have that's one part. But then you have a matter of sort of a motivation, and that is obviously we are responsible for making the child as motivated as we can to learn, basically, because. And I think that is if you can make the child motivated to learn, I think teaching the child is okay. I think it's quite difficult to say that wouldn't be okay, because we are also obliged to try to help the child to develop, and basically, if you want a child to be able to make their own decisions and live as independent as possible, obviously, many of these children need to learn skills. And so we are sort of obliged for that too. But basically, we need to not be aversive to the child, and then we need to make sure that it's effective what we do. Because if it's not effective, we shouldn't continue.
I think you're completely right. I would agree with you completely in terms of there are some situations where children have to learn skills like toilet training. Many 2-year-olds, 3-year-olds, they don't particularly want to get toilet trained, but it is one of those skills you just have to have. Otherwise, you can't move on with other independent skills, because the kindergarten will not take you, or the play school will not admit you. So, and there are very few 2-year-olds that are sort of saying, "Yeah, I want to be toilet trained." They don't tend to do that. They tend to, like, rather object to that. So you, as you say, you have to motivate them and find the right reinforcers, basically, that motivate them to learn these skills that might not be particularly nice skills to learn, but you still have to have them.
Yeah, exactly.
And find the motivations. And I think this idea that ABA-based interventions do harm. Well, if they do harm, then we should immediately stop them.
Yeah.
Yeah.
Definitely.
They definitely should not do harm, because that is not what the definition says. If they're not socially important, if they are harmful, then we shouldn't be doing them.
Yeah.
We shouldn't be calling anything like that ABA if it's not, if it's doing harm.
Yeah, absolutely. Yeah, definitely.
Yeah. So I mean, the debate around this whole the debate that coming through from some autism self-advocates is very interesting, because it's of course really important that people are listening to what they have to say, but it's equally important to remember that they generally don't speak for the more profoundly affected young kids that we would work with.
Exactly. Yeah, I think that's an important point. That so these are speaking for a very narrow group that should definitely be listened to, but I think that they don't have all answers. Also, we should listen to what they say, but they are very eager to sort of tell other people what they should do, and I think that sometimes they are not helping the children. Actually, they are maybe doing. They are actually, that could actually be harmful for the children if they are losing access to effective treatment because of these arguments, and that's. I have parents saying that they are being approached by those people who are skeptical and sort of giving them a hard time because they use EIBI. That's not really something that they deserve, the parents.
Yeah.
So it gives them bad feelings about what they're doing. So
yeah. Well, I mean, there weren't any further questions from the audience. I'm just interested. I could debate with you for a long time, and would be really, really interesting to carry on. But we really, really appreciate your time, and thank you so much for coming to the webinar and volunteer, or accepting the invitation so willingly and so well. And we'll definitely very much appreciate it, Svein, and I hope to see you in person again sometime soon.
Yes, likewise, and thank you very much for inviting me. It was a pleasure to talk to you, and yeah.
Well, thanks very much. There are comments here from people. Devin is saying, "Thank you very much, Professor Eikeseth. It was an honor to listen to you." Devin is one of my colleagues at Queen's, so that's really
thank you.
People have people.
Those are good reinforcers.
Yep, and different people. Everybody, you can probably see the comments here now yourself. You've got time. You don't have to present anymore. Everybody is very. There's somebody even telling you in Swedish or Norwegian too.
Yeah, in Swedish, exactly. Elin. Hi, Elin.
There was a lot of people from Sweden listening, and of course a lot of Americans and a lot of other people from other European countries as well. Yeah. So, okay. Well, thanks very much, and
then maybe I see some of you in the US in ABBA conference coming up soon.
Okay.
So, yeah. Take care.
Okay. Bye-bye.
Bye-bye.